19 have increased by just over 70%. And in addition to those increases, as of the last week of past, the number of people being admitted with confirmed COVID-19. This is significant because this is the first respiratory disease season we have had during which both people admitted with confirmed COVID-19 infections and confirmed influenza infections have been this high at the same time. During the last influenza season, which was the winter of 2021-22, confirmed influenza admissions peaked at 109 in a single week. However, during that same week that confirmed influenza admissions peaked, the number of confirmed SARS-CoV-2 admissions was only 18. This was in the late March of 2022, right after the Omicron surge. And during the 2020 to 2021 influenza season, so this is the very first respiratory season after the pandemic started, Idaho peaked at 23 confirmed influenza patients in a single week, while 150 confirmed COVID-19 patients were admitted the same week. So in a nutshell, here we are. Respiratory illness looks very different this winter compared with the last two that we went through during the COVID-19 pandemic. Until this current respiratory disease season, hospitals have not had to contend with both high numbers of confirmed COVID-19 patients and high numbers of confirmed influenza patients, while at the same time, we have high levels of RSV circulating in the community, a virus for which there's no vaccine, and puts some people at risk of hospitalization, including older adults, very young children, or people with certain medical conditions. So to help us understand the hospital perspective better, I'm now going to turn it over to Dr. Jim Souza. He's the Chief Physician Executive for St. Luke's Health System, and he'll provide his perspective on the impact of these respiratory viruses on their healthcare system. Dr. Souza?
Awesome. Thank you, Dr. Turner. And thank you to our colleagues in the media for helping us get the word out. My comments will be focused on St. Luke's, but I think much of what I'm going to share is more generalizable to the hospital situation generally across the state. First, an overall comment for context. Overall inpatient volumes in our hospitals has been really high, frankly, since the end of the Omicron surge in the spring. We've never gone back to the sort of lower volumes we would typically see, for example, in the summer. For sure, we got a little more breathing room in the summer, but for the last couple of months, that's been eroded, driven by the changes in the respiratory viruses that you were just hearing about. And I want to be clear, this isn't just our issue in our part of Idaho or in Idaho. It's a Pacific Northwest issue and more generally, an issue across the United States. Hospital census across the Pacific Northwest has been at or near capacity over this same period of time. And over the past few months, our health system has had transfers in from as far away as Sitka, Alaska, multiple from there, from the Oregon coast, and from Northern California. Now, what's happened lately, I want to pivot to the triple-demic respiratory wave that we're seeing right now and speak to how these specific viruses are looking inside of our hospitals. So with the RSV curve that you saw, I think you know this is mostly affecting children, especially the very young, less than 2 years, and especially those under 6 months. The main issue with these kiddos is airway inflammation and mucus in their really small airways. We are seeing some severe cases in certain adults, especially those with pre-existing lung disease like chronic obstructive pulmonary disease. For the adults, this can be lethal. And for the kids, it can prevent it can be a severe acute illness that requires hospitalization, suctioning, and oxygen. With flu, as you just heard, we're seeing sharp and early upticks in influenza cases in both adults and kids, and that curve is still on the upswing. Significant increases in both pediatric and adult flu admissions, including intubated and mechanically ventilated adults with flu. today in our health system, we have about 50 hospitalized patients with influenza. We are also seeing lots of post-influenza, so patient gets the flu and then goes on to develop bacterial pneumonia. We've always seen that. I think our general feeling is we're seeing even more of that, and we've even had a handful of group A streptococcal infections. With COVID, as you saw, our testing has also been running on a plateau, and our inpatient hospitalized COVID census has pretty consistently been between 30 to 50 a day in our health system. And what we're seeing clinically is that it's mostly either a co-traveler, so we're picking it up incidentally and someone admitted for another reason, or it's the driver of an exacerbation of an underlying condition like chronic obstructive lung disease. Briefly, the things we're doing to manage this surge and the really high volumes that we're contending with right now, whole bunch of adjustments, and frankly, they're all pretty similar to the sorts of things you saw us doing during the COVID surges. This includes changing nursing ratios, caring for certain patients in different units than we usually would, pulling in additional help to support the provider workforce. So advanced practice providers, PAs and NPs from other pediatric duties being pulled in to support inpatient care, and they've been amazing. Pulling in some of our primary care pediatricians to also support inpatient pediatric care, and they've also been amazing. We've been managing a whole bunch of drug shortages I could talk about if there are questions. And then relative to RSV, we've been trying to go upstream with this suction clinic, which I could also talk more about, where we bring appropriate kids in up to multiple times daily for suction treatments in order to keep them out of the hospital. We've also been managing kids at home with oxygen and oximeters and close follow-up with their pediatricians and family docs. I'm going to close just briefly before I turn to my colleague, Dr. Hahn, with what you might expect if you're the family of a sick child, or you're an adult with a respiratory illness, or really you're anyone who needs to go to an emergency department or potentially needs inpatient care. Some of the things you might experience right now because of these shifts and because of what we're managing. You will experience very busy emergency departments, crowded waiting rooms. Everyone will be wearing a mask, but they are crowded. You'll experience longer waits because of that. If you need to be admitted to the hospital, you might experience needing to board in the emergency department, which means spending more time in the emergency department before we are able to open up a hospital bed. Your care might occur in a different place. The drugs and supplies we use might be different, and we might even need to cancel elective surgeries. We had to do this in pediatrics this week, something we really want to avoid. So with that, I think I'll stop and I'll pass it to Dr. Hahn, and I'll be ready during Q&A for any questions our media partners might have. Dr. Hahn?
Quick sound check. Can you guys hear me okay?
Yes, we can hear you, Dr. Hahn.
Great, thank you. Yeah, thank you. I'm going to shift a little bit. We wanted Dr. Souza to paint a picture of how things are in the hospital, and we just heard a very sobering report from him. I'd like to talk about how we're working together to keep Idahoans healthy and keep those hospitals open and available for all of us, whether that's an older adult who's very sick with COVID, a person with cancer who's now developed a nasty case of the flu, or a baby who can't breathe and maybe the suction clinics aren't enough and needs to be admitted. So focusing on what can you do if you're not if you're feeling well, which we'll be talking about. Many of you heard us talk about these measures, but what happens if you get sick? What if you get a cough, a fever, a sore throat, or other symptoms that suggest you may have been infected with one of these viruses that are circulating? The symptoms of flu, COVID, and even RSV can overlap a lot. And Dr. Souza also made reference to group A strep. All of these could present potentially with upper respiratory symptoms, sore throat, etc. And really, it's not possible to tell which one you have based on your symptoms alone. You may have a guess because if you know you've been exposed to somebody, but you don't know for sure without some type of evaluation and testing. In addition, it's important to be aware that although these viruses can be mild in some people, you may say, oh, I think I got that COVID that my coworker had or my household member. It may cause more severe illness in you if you have underlying health conditions. So think ahead about how sick you might get and be ready. So the first part, I have 3 things I'd like to emphasize, and those are knowing your risk for severe disease, knowing if you're at high risk, being ready to test if you get sick so that if you are at high risk, you can get tested quickly. And then also knowing to ask whether antiviral treatment could be the best thing for you if you do test positive, whether it's for flu or for COVID. There are antiviral treatments for both. So let's start with knowing your risk. Some people are at higher risk of having a severe bout. And for flu and COVID, they're very, very similar for the most part. So if you are an older adult, and the older you are, the more your risk will increase over time. So if you're an older adult, if you have a medical condition, Dr. Souza referred several times to chronic obstructive pulmonary disease. If you have heart disease, asthma, diabetes, obesity, or a weakened immune system from cancer, you are at higher risk of severe disease from flu or from COVID. If you're pregnant, so you're like, well, I'm none of those things. I'm young, I'm healthy, but if you're pregnant, you're also at higher risk for severe disease, and your baby could be impacted as well. And this is all especially true if you have not had a flu shot and an updated booster shot this fall. So your immune system, even if you previously got vaccinated, even if you previously had COVID and maybe you had flu in the last few years, we know your immunity to all those things will wane over time. So it is important to be up to date on your shots. But if you have not, you are at higher risk of severe disease. We do have more details about who's at high risk that I think Nikki is putting into the chat right now, available at the CDC link. That is for people that want to read a little more detail about who's been determined to be at highest risk for severe COVID. The second point about knowing where to get tested. Only testing can tell the difference between these viruses for sure, and possibly a doctor's evaluation, or in the case of group A strep or pertussis or some other diseases, maybe even other types of testing. So knowing where you'd go if you thought you might need to be evaluated is important. Many of you have a home COVID test. That's great. If not, know that you can pick up at-home testing kits. They're for sale at local pharmacies, but in addition, many insurers, including Medicare, provide free tests that can be picked up at your local pharmacy. And I think we're putting that Medicare link into the chat for Medicare patients who want to make sure that they could get testing and have that available if they need it. And there are also additional free testing sites throughout Idaho, not a home test, but where you can go in and they will do testing for you. And we're putting that link in the chat as well. Those are all from the Health and Welfare site, a list of those places. And then lastly, for testing, just today, the federal program was relaunched that allows U.S. households to order up to 4 free COVID tests. And I urge you to do that today. My husband texted me, he already put in his order so that you're sure that you've got tests at home should you need it. That is really the fastest way in many cases to get immediate testing. So why is this so important to get early testing is that we'll now turn to a treatment. First of all, it's important to know because you can stay home, protect others, but we're recommending you do that in any case if you don't feel well. But most critically, you can get antiviral treatment if you have COVID or if you have influenza, and it's important to know that so you can get treatment. These medicines work best if they're taken early in the course of illness, just in the first few days of illness. So if you wait too long, you wait till it gets too bad, too severe, you've been coughing for a couple of weeks, by then those medicines will not be effective. So that's why we're emphasizing early and quick treatment if you do get sick. We're also providing a link. There's a treatment locator for where some of these COVID medications are available. Again, work with your provider, check with your local pharmacist, but there's also a website that lists places that do have some of these treatments available, and you can call them to get more information. I do hope that everyone listening stays healthy this winter. However, if you do get sick, it's important to know where you can get tested or have your home tests available, and if needed, where you can get treatment if you are at higher risk of getting severe disease, so you can stay healthy, recover quicker, and hopefully not end up having to go into the hospital. With that, I'd like to turn things over to Elke, the Division Administrator for Public Health.
Dr. Hahn, and welcome everyone. So you've heard already a lot in this media briefing about the impact of this current respiratory surge. And while you've only heard from one healthcare system on this briefing, as Dr. Sousa mentioned, we know that this is happening across the state. We convene calls with our hospitals statewide multiple times a week. And during those calls, we hear of these stresses, the stresses of high hospital census, staffing challenges that continue to exist across the entire state. You've also heard about the importance of taking measures to protect yourselves, your loved ones, and our valuable healthcare resources across the state. We have tools at our disposal to slow the spread of contagious diseases. When we took those precautions in the height of COVID-19, they did work. We know they will work during this surge of respiratory illness. Wear a well-fitting face mask when you go to an indoor crowded area during the surge. It prevents both getting and giving the respiratory infections. Get vaccinated with a COVID-19 booster and get vaccinated for influenza. I know that vaccinations are the most important way to protect against severe infections, including hospitalizations and death. Everyone aged 6 months and older should be vaccinated against flu and COVID-19, and those who are eligible for an updated COVID-19 booster should get it now, and it's not too late. Stay home if you're sick, even if you're a little bit sick, as Dr. Hahn was talking about, because sometimes symptoms are so mild, you might not be aware you have COVID-19 or another virus, and then you can spread it inadvertently. Wash your hands often and avoid touching your face with your unwashed hands. We're excitedly approaching another holiday season, and we have all of our festive activities occurring, which means a lot of opportunity to be around a lot of other people indoors, whether you're shopping, attending a holiday party, or other holiday events, and many other reasons to gather. While it might be challenging to avoid these indoor gatherings, and you want to be a part of it, I do want to really emphasize the value of wearing a mask, as well as laying those other precautions I talked about, such as vaccination. Taking these precautions for both you and your kids works. We know it works. Vaccines are a safe and effective way to quickly boost your immune system to avoid getting seriously ill. We're here today sharing these messages with you and asking you to take these measures because this respiratory surge and the stress and strain on our healthcare system is very serious. Keep you and your loved ones safe this holiday season. We don't want your holiday gift giving to be the gift of sickness. And we also want everyone to have a happy and healthy holiday season. And I'll turn it over to Nikki so we can start our question and answer.
All right, thanks, Elke. Okay, so we will now take questions from the media on the call. Please raise your hand in WebEx or type your question into the chat. When I say your name, go ahead and unmute yourself and announce your name and media outlet before asking your question. And then please try to remember to clear your hand when you're done so there's no confusion about who has additional questions. We'll start today with Audrey Dutton.
Hello, Audrey Dutton from the Idaho Capital Sun. I think that my question is mainly for Dr. Sousa, but also maybe Director Jepson. The data for pediatric bed capacity and occupancy in Idaho only really is available back to February through HHS Protect. So we just didn't have the data and we didn't have as much attention to hospital capacity before the pandemic. So I think my question is, how unusual is it for hospitals to be slammed like this when it comes to children's medical care?
And
I can take that. It's unusual, Audrey. We are used to seasonal surges. The wintertime is known in our children's hospital as the busy season. The frequency with which, however, we would find ourselves at our pediatric ICU, for example, capacity is exceedingly rare. And certainly the frequency with which we would need to decline transfers from other places, either around the state or from other states is rare. We did manage a big pediatric RSV surge it was an odd time, the summer of 21, but it didn't come close to this one in terms of the kind of the volume that we've seen, and as well as the acuity of illness. I mean, we have not had to surge our children's hospital into our adult hospital before. We have had to do that. We have had to put, sick children who typically would be in a PICU in our NICU. We have taken kids who, don't have a respiratory acute illness and are hospitalized for another reason and put them on adult med surge floors. We've taken near adult sized children who usually would be cared for in a PICU or a pediatric floor setting and moved them to adult ICU or adult floor. In terms of the number of beds, there's only 12 in our part of the state, 13 maybe if we get creative with our PICU, and there are 4 in Idaho State, Idaho Falls. If you compare that to a state like Oregon and normalize it for population density, we're right in the ballpark. And again, usually we don't see anything like this. So this is really a triple-demic. And unfortunately, what's happening right now, like this week, is while there's this optimistic news that you saw about potentially turning the corner on RSV, we're getting more and more pediatric and adult admissions with influenza. So while the one virus may be reaching its peak, the other one's not even close. Did I answer your question, Audrey?
Yeah, that did. Is this our new normal?
Let me say it this way. I hope not, but I believe that we will face challenges like this on a more frequent basis. I'll maybe repeat today some things I definitely said many times during the pandemic, but at the start of my comments here today, I mentioned that we never really kind of got that summer relief, right? And we've been running at or near capacity really since the end of the Omicron surge, just very busy hospitals. What's driving that? Well, we've got population growth, we're growing rapidly, and the segment of the population that is growing more rapidly than any other segment is the over 65 adult population. That's significant. That's a population that tends to utilize acute care hospital services at a greater frequency. They need it more often. They have more chronic conditions like Dr. Hahn was talking about. Number 2, we believe that there really has been an impact to the public health that was driven by the COVID surges with delays in care and kind of backups in primary care and chronic diseases that went suboptimally managed. We know there has been a significant increase, and if you look at it on a curve, I'm going to use my hands, it doesn't look like a spike, or it just looks like a surge that's gone up and never come back down. A significant increase in substance use disorder presentations to our emergency departments, including intoxications and withdrawal presentations, as well as an increase in behavioral health diagnoses as either the primary diagnosis or a secondary diagnosis. What's driving this? Again, we think it's the behavioral health and substance use tail of the pandemic. It's a pretty well-known fact that alcohol use, for example, went up in a very significant and very unhealthy way during the pandemic, and it doesn't appear to be coming back down. So all of these things are driving basically a capacity that's closer to the top, which, to answer your question, means that the frequency with which we hit the top is going to increase.
Okay, thanks, Dr. Souza. Our next question is going to come from Melissa Davlin.
Idaho Public Television. I was wondering if there's been any conversation in terms of a post-Christmas surge about possible crisis standards of care in terms of either, hospital-wide issues or just as it relates to the PICU or pediatric care or anything like that.
And Melissa, I'm going to address your question to Director Jepson first and then have Dr. Souza follow up.
Melissa, it's an excellent question, and one that's, I'm sure, is on many people's minds. We are worried about that. We unfortunately have a process and a method of how we put crisis standards of care into place across the state. Part of that involves convening a crisis standards of care activation committee. We did pull that committee together, not to discuss a specific situation, but just to prepare them in case we did need to get them together just here in the last month or so. From a statute perspective, the Idaho legislature passed a crisis standards of care law in the last legislative session, which largely aligns with our practice and what we've done in the past. So we are prepared should we need to go there. All of us hope that is not where we end up. All of us hope that we can navigate through this surge without entering crisis standards of care. And I'll let Dr. Souza speak to this, but we've moved past normal operations and we're in what we call contingency operations. That's the it's not quite the crisis, but we're doing things that are not normal. And that always puts us at risk if we see a significant surge that it is possible we could get there. Again, we hope we don't, but we're prepared to act if we do. Dr. Souza?
Thank you, Director. Yeah, I won't predict whether we will or won't. About 6 months into the pandemic, I shattered my crystal ball. Certainly hope we don't. We are preparing, though, as you heard from the director. So while the state is preparing to receive a request, we are preparing for what that request could look like and that possibility. And, right now teams are meeting to decide if we were to get there, how would we make decisions in our children's hospital to allocate resources under a crisis declaration. The director's correct. We're operating in contingency, which in plain English means that we're flexing, we're stretching, we're innovating, things like that suction clinic to try to continue to provide a basic standard of care. But I want to make sure I mention in the event there are healthcare workers who hear us talking about this, that we see them and know that even though we're operating in contingency mode, our healthcare workers are struggling with a crisis around the fact that they can't provide care in the usual way that they're accustomed to. Healthcare in the United States it comes from an abundance culture. And when constrained, it doesn't feel great. And I want to acknowledge that.
Thank you so much.
Were you saying something?
Thank you.
Okay. Okay, our next question will come from James Dawson.
Hi, James Dawson, Boise State Public Radio. Director Jepson, you just said that IDHW was prepared to act, but just reading a story that Audrey posted, I guess it's an interview with Dr. Kenny Bramwell shortly before the call, he says that you're just now having discussions about crisis standards of care for pediatric patients and that those are being developed over the next few weeks and you can't actually declare crisis standards of care until you have those rules. Is that true? And if so, I mean, how long do you think it might take for these to be put in place should, the surge continue?
Great question. And Director, do you want to go ahead and start, and we can join in on the rest of the response?
Sure. Thank you. Thank you, James. Excellent question. I haven't had a chance to read Audrey's article. And knowing Audrey, I'm sure it is very thorough and very good. But I can speak to the situation. So crisis standards of care, it really, at its most basic level, means that the demand for healthcare exceeds the supply. And that's really the trigger that puts us, and where you're now making decisions that are no longer the usual standard of care. And that can certainly apply across a wide range of services. During the pandemic, we saw that around bed capacity. We saw that inch close around oxygen supplies. We saw that around staffing levels. And so certainly that is the case. If we end up in a situation where we no longer can serve, let's say, children or pediatric in the usual way, that would be enough to trigger crisis standards of care. What Dr. Bramwell, I'm sure, I don't want to speak for him, but I'm sure is referencing is that in our crisis standards of care guidelines, we have a number of areas of medical care that are just guidelines that really just detail out, here's how a hospital can think about whether they're entering contingency or crisis situations. Those are really meant to be just guidelines. They're not hard and fast rules. Dr. Bramwell is correct. We are convening the State of Idaho Disaster Medical Advisory Committee to revise our pediatric guidelines that are out there. And we hope to get a better, more finely tuned set of those to help hospitals as they make these, if they have to make these difficult decisions. And that will take a couple of weeks to get that revision done. But we do have a set of pediatric guidelines that are out there today. And ultimately, a hospital will, and its operations will know if they reach that tipping point where we're no longer able to provide the usual standard of care and gone well past contingency operations. So we are working diligently to try to fine tune the tools that we use, but I think if need be, and if a request came, we would be prepared to act when that happened. And Elke, I don't know if you want somebody else to add something there.
I think you summarized it well. You got all the points.
Thank you.
All right, our next question is going to come from Jude Binkley.
Jude Binkley, KTVB. Dr. Souza mentioned drug shortages that they've been seeing. I wanted to know if that's affecting the administration of antiviral treatments and then just where that shortage is coming from.
Thank you, Jude. I'm going to let Dr. Hahn talk about the antivirals first and see if Dr. Souza wants to add anything.
Yeah, I'll say that at the national level, the FDA does not believe there's a real shortage, but that due to the sudden increase in demand, because as you've heard from Dr. Turner and Dr. Souza, we've had this sudden jump in influenza activity, including hospitalizations. There's been it's like the local supplies just got kind of sucked up and used. So there have been sort of some spot shortages. To our best of our understanding, there is not actually a drug shortage for influenza medications, but I am curious to hear what Dr. Souza tells us about any challenges they've had in the hospital setting. And to my knowledge, these types of spot shortages can also affect, for example, antibiotics. We talked earlier about there's been some strep going around. There's been other things where the doctor just isn't sure and might prescribe antibiotics. So sometimes we'll see some of the commonly used antibiotics that are used for kids with upper respiratory infections, sometimes in spot shortages. But I'm not aware of any severe or ongoing shortage of any of the critical medications. But I've been curious to hear how St. Luke's is experiencing it.
Yeah, thank you. Good question. I think the best way to describe what we're experiencing right now is that we are rationing and we're not yet restricting. So the drugs that in particular are problematic, I mean, it blows me away that we're struggling with things like this, but children's liquid Tylenol, ibuprofen, amoxicillin, Augmentin, albuterol, and a handful of antibiotics that are in the class we call cephalosporins. I mean, these are common drugs, and we're running low. Again, we're not managing that with restrictions, so we're not finding ourselves in a situation where a must-have use is not being allowed. But we are, through our electronic health record, when a provider, a physician, a nurse practitioner orders one of these drugs, they've got to manage a pop-up screen. Is there anything else you could use? Have you considered these other alternatives? Could we try this instead of that? So that's the situation inside the hospital, and no issues that I'm aware of, as Dr. Hahn has pointed out, with antivirals.
All right, it looks like our next question is going to come from Sherry Fink. Oh, looks like she lowered her hand. She did put a question in the chat, which I'll go ahead and read. She asks, have the guidelines for adult crisis standards of care been updated and fine-tuned based on the experiences from the pandemic?
Great. Thank you for that question, Sherry. And the short answer is no. They've been developed during the course of the pandemic through as the director mentioned earlier, the State of Idaho Disaster Medical Advisory Committee is the one that's been working on those guidelines for resource constraints. So no changes to the adult pieces have been made, although there are impacts, as the director mentioned, with the new Crisis Standards of Care Act. But Director, I'll see if you want to add anything to that.
The thing I would just add is we continue to look at those guidelines. We're very thankful to the State of Idaho Disaster Medical Advisory Committee, and as I mentioned, we're in the process of revising some around pediatrics, and I anticipate over time we'll continue to revise and update those as well, or the ones around adults as well.
Our next question will come from Melissa Davlin.
Thanks so much. Had a question about data visualization. I know that, for so many of us, the COVID-19 dashboard page was really, really helpful for so much of the pandemic. Has there been any discussion within the department of making something as it relates to hospital capacity as a whole in terms of the triple-demic and how it's affecting pediatric units and that sort of thing?
Great, Melissa, that's a good question. I'm going to turn it over to Dr. Turner.
So Melissa, the data that the hospitals report to us, like what I went over, is actually available on the HHS Protect public site. It won't go into great detail about like individual hospitals, but it does give a statewide picture. And I know it's been used by the media quite frequently to check on our capacity. So, but that being said, Melissa, if there's specific things that you would like to see us make available publicly that isn't available somewhere else, we are totally open to that and creating access to that information if it's not available.
I know that for a few of us, region by region, at least, or health district by health district, was very helpful during, tracking COVID upticks during some of the worst surges. And so if that would be a possibility, just something to throw out there. I was also wondering if there's been any discussion with providers about standardizing RSV testing. I know in a lot of parents' experiences that I've talked to, they've taken their sick children in, and partly because everybody is so overwhelmed, they haven't necessarily been tested for COVID, or they haven't been tested for RSV. Is there a discussion about the approach to make sure that these respiratory diseases are being tracked properly, or does it matter that much as long as the kids are getting treated for their symptoms?
That's a great question, and I'm not sure who to hand that off to, actually. So it's multi-pronged. So maybe I would start with Dr. Hahn, if you want to address it, and then you can hand it over to.
Yeah, thank you. Elke, I do have some comments on that, so thank you. I was thinking about that. This gets into that delicate issue of the role of public health in medical care. As you know, we don't dictate, nor do we have control over the practice of medicine. And so the way we handle that is that, yes, like you said, and I tried to emphasize, we do recommend medical evaluation. And it is important to know if your child has RSV, flu, or COVID for the reasons we've talked about, especially if they're of an age where they could be at risk. You know, I didn't focus a lot on the RSV piece of it, but of course we know the very young infants, as Dr. Souza alluded to, are at highest risk of severe disease. Some children are on need prophylactic treatment throughout RSV season, kids with certain heart or lung conditions. So yes, diagnosis is important, but I would, other than making sure providers are aware, we just put out a health alert. I think CDC released it yesterday, actually, about influenza and some of these medication challenges and some recommendations for how a provider could handle if they don't have a lot of treatment available. We continue to push recommendations out, but we don't tend to, of course, and we recommend testing for the reasons I talked about, but certainly the practice of medicine, it might be a provider is very comfortable with a diagnosis in a certain case. For example, if something's going around in a household. So there might be situations where they don't do testing. And I don't know if anyone else has anything to add to that, but I would just say we work mostly through education and promotion, making sure providers have the information they need.
Dr.
Thank you.
Souza, do you want to add anything on?
Yes, sorry, okay, if you call, I hope you were calling on me.
Yes, I
Yeah,
was. Sorry.
For any number of conditions, including respiratory viral infections, right, our teams of physicians will collaborate on guidelines and standards. And in medicine, you know, I think a good rule of thumb is the kind of 80-20 rule, meaning that 80% of the time, the individual patient will land inside a standard like that, and we follow it. But caring for individual patients is quite a bit more complex than any single standard can drive. I mean, that decision to be tested can be polluted by something as, well, out of control potentially of the patient and the provider as their health insurance product or something, or their copay that they would have to pay, or whatever. At the point of care where the decision occurs, it is individualized, as Dr. Hahn points out. But yes, we develop standards and try to adhere to those standards.
Our next question will come from Audrey Dutton. Audrey, if you're speaking, we can't hear you.
Oh, sorry about that. It was bound to happen.
I know.
So, is there anything that the state can do to help with this? Oregon has issued a state of emergency. Of course, we saw funding from the federal government and through the state for COVID surges to pay for travel nurses, overtime, things like that. Is there anything that the state could do to help with this?
Thank you, Audrey. I mean, that's something that we evaluate all the time. There were definitely funds that were available that were COVID specific. It gets a little bit trickier when it's not specific to COVID right now, and trying to find the resources that provide 100% match for the hospitals and healthcare entities at this time without an emergency declaration. But excuse me, but certainly, as I mentioned, we meet with the hospitals multiple times a week, listening to what's going on, trying to understand exactly what the constraints are, and evaluating what the benefits would be of any further actions, and trying to solve for things before getting to, you know, a point of crisis. But that said, like I said, we're constantly evaluating that, and Director, I'll see if there's anything that you want to add to that.
Okay, I think you've covered that. I don't have anything to add to that.
Okay, our next question is going to come from James Dawson.
Dr. Souza, you mentioned that, you've had to kind of move pediatric patients, into the PICU or the NICU or the ICU, other places in the hospital, to accommodate them. Do you have enough supplies and equipment in those alternative locations that can properly fit these younger patients? I'm kind of thinking like oxygen masks or maybe needles that are kind of smaller than the ones used for adults.
Yes, great question. Thank you for asking it. Yes, we do. And it's also just as important in the care of children that we have staff experienced in doing that. One of the ways that within our health system, one of the kind of cool cultural things, if you will, to see is that our adult ICU nurses who just got shellacked during the COVID surges, and our children's hospital ICU nurses didn't. During the COVID surges, they came to help in the adult ICUs. We're seeing some of the same volunteerism and, adult ICU nurses helping out in pediatric units, not taking the assignments, but being like assistive personnel to help with tasks and things that the pediatric nurses need to accomplish. That's been a really cool thing to see, and it's just one more brick in the giant wall created that proves that healthcare workers are amazing people.
All right, I am not seeing any more hands raised or questions in the chat. We'll give one more minute or so for any last minute questions.
Quick.
Sure.
I know that the state tracks COVID and flu deaths. Does the state announce RSV pediatric deaths?
Thanks, Melissa, and I'll ask Dr. Turner to address that question.
Yeah, thanks, Melissa. If that were to occur, we certainly would alert. It would depend on the circumstances, of course, but we would definitely consider alerting the public.
Thank you.
Nikki, you're on mute.
Yes, thank you. See, I did that too, Audrey. So just so you don't feel bad. Thanks for joining us today. We'll go ahead and wrap it up. We are recording this briefing, and we will be posting a link to that recording on our Twitter and Facebook accounts. We'll also be adding a link to that to the press release that is on healthandwelfare.idaho.gov, our website. So thanks for joining us today, and happy holidays, everyone.